My Christian, I'm gonna try to your CV first, and then you can start. Ben Christian'ın kısa bir CV'si var elimde, onu okuyayım. Böylece de Prof sempozyumunun ikinci oturumunu da başlatmış olayım. Hepinize hoş geldiniz diyerek. Gayet kısa bir CV'si var Christian'ın. Koruyucu ve pediatrik diş hekimliği bölümünde Almanya'da çalışıyor şu anda. Ama eğitimini İngiltere, Leeds'te, Amerika'da yapmış. Çocuklarda çürük prevalansı ve çürük değerlendirmesi ve riski önleme konusunda da doktorasını tamamlamış. 2019 yılında Orta'nın başkanlığını yaptı Christian. Şimdi Vice President olarak görev yapıyor. Pediatrik dentistry, karyoloji, epidemiyoloji, preventif dentistry de Christian'ın ilgi alanları diyebilirim ve şimdi sözü ona bırakalım. Okay, Christian, you can start now.
Okay. Thank you very much for this very kind introduction, and I hope everybody can hear me there. Can you say yes, hello, all fine? Yeah, looks like it. Okay. So I want to give a lecture on how to intervene in the Caries process in children, and it is a joint ORCA and EFCD expert Delphi consensus statement. And I mean, I used to be the ORCA president, but you can't do that on your own. And so I had two partners and friends. One is Falk Schwendecke from Berlin, and he did the How to Intervene in the Adults, and that's also published. You can read all our statements and all our consensus in 2 Caries research papers and 1 in oral investigation. So my lecture will be totally based on these publications. And the other friend is Sebastian Caries from Berlin also, and he did the story How to Intervene in the Caries process in seniors. So, first of all, I want to tell you who and what ORCA is. ORCA is not a big whale swimming in the Atlantic. ORCA is the Organization for Caries Research, and if you are interested, we are doing our annual congress this year from 5th of July to 8th of July in Egmond aan Zee, which is in the Netherlands, and it will be a great and for the first time after Corona, without any restrictions, annual congress. And it looks like there, I mean, Turkey has nice warm sea, Mediterranean, but the North Sea in the summer is also fine. It's at a big hotel at the Dunes, and we have a very interesting program, something about dental public health interventions first. And then we have making decisions in the primary and secondary caries. And we have with the European Conservative Association also together the dilemmas in daily dentistry. And you can look up the program in the internet and register there. You missed the abstract deadline, but you can still register. And those are the fees, and I hope to see many of you then in Egmond and See, and then we can discuss topics there. But now back to my original topic, the how to intervene in the Caries process. I want to send you first greetings from Greifswald. That's actually how it looks here. We have brilliant sun now. We are a tiny medieval city just north of Berlin at the Baltic Sea, so we have nice water here as well. We are very touristic season, and we are really in the middle of Europe. We are somewhere between Lisbon and Moscow, and between Iceland and Turkey, Istanbul. We are right at the middle here, just north of Berlin. And I have to get the right button here. And if you see here, we have a very mixed history. We used to be Slavic tribes here. Then there were Germanic tribes. The Danes, 1,000 years ago, they came across the water and they founded our nice city here. Then we had the Swedes in for 200 years, 1600 to 1800. And if we look out the window here, we can see almost Sweden, just 100 kilometers with a ferry. Napoleon marched on his way to Moscow, passed here and kicked the Swedes out. Then it was Prussian, then it was unified Germany, and we had the Russians in here for 40 years. Now they are in the Ukraine, but they used to be also here. And now it's unified Germany again. And as you can see, that's where actually the Danes came in, and you see actually a Dutch bridge as well. So we are a small university. That's what it looks in the winter here. So pretty cold sometimes, but now with global warming, we don't have that so much anymore. And we are one of the most touristic seasons in Germany. And it's a nice medieval city in really good shape, no big highways, all nice and very touristic. That's what you do here for vacation. We have lots of islands around us, and that's the famous chalk cliffs from Rügen. We even have a nicer one with the Brits. We have trees on top. Sometimes they fall down. And we've been a university from 1456. And since that time, you could study medicine here. You could study arts, science, theology, and dentistry is a little bit over 100 years. And that's our new building. And I'm here in the back office there. And so we are a big integrated clinic. And that's the pedo department that's where we do our GAs, regular treatment, the nitrous oxide room. So, and we also have a postgraduate master program, which is international. We have folks from China, from Hong Kong, from all Arabian countries, from Mexico, from Lithuania, from Greece, from Netherlands, from Portugal, wherever. So we are I think actually the biggest program, at least in Europe. Maybe Istanbul has bigger programs. And that's where you can register and get some information about the master program. And there we do lots of teaching here with lots of partners in other cities. And we have a joint German master. And you see many cities and many specialists, many practices. And you do fun things there, except for dentistry. And in the end, you defend your thesis and then you get your degree. So now after I introduced myself, what I normally do, I want to tell you about how to intervene in the caries process in children. And these are all the distinguished names and places from all over the world, people that took part getting this consensus. We were 24 people. And the three folks of us were the chairperson that organizing this process. And here you can see the paper with all the 24 names on it. And you can download the paper. I think it's even for free. And you can download also the seniors papers and the adult papers. So all the statements, you don't have to take notes. All the statements I will explain are included there. But how do you reach consensus? I mean, it's not boring expert discussing on a round table. You actually need something like evidence, and you need unbiased partners. So ORCA and EFCD nominated 12 people each, making 24 together. And these nominated people, democratically elected, they were supposed to do the consensus. And the consensus was based on systematic reviews. So we had 6 systematic reviews, and 1 was on seniors, 2 on adults, and 3 on children. And the questions for pediatric dentistry were on early childhood caries. So something like anteriors, very small children, 2, 3, 4 years, and really broken down teeth, mostly anteriors. Then about primary teeth, mainly posterior teeth, primary molars, and the occlusal surface of the 6-year molar. And these 3 systematic reviews looked what evidence is there for different statements. And then after these systematic reviews were done, our expert committee started to develop statements, recommendations. And these recommendations were either strong, moderate, or low evidence, weak, because due to the systematic review. And then the experts had the chance to vote on them if they agree, and then we had consensus, or we didn't. So I already told you that if we look at early childhood caries, we have the question, what is the effect of non-invasive treatment? So not drilling, anything before drilling. And what's the success of operative treatment? And then how should we intervene in caries in primary molars? And the last thing is the 6-year molars. And so actually these are all the statements, and that's my lecture, and then we are finished. Now, I start to explain all these different topics here, and we go slide by slide, and so it will be a couple of slides for every topic. So the patterns of early childhood caries vary from normal caries. I mean, it's almost art or on purpose if you want to destroy teeth like this. I mean, it's okay if you don't brush your teeth really well, then in between the teeth, interproximally or on the occlusal surface, because there are pits, fissures, and grooves, you might get caries. But in order to get something like early childhood caries on your anteriors, and that's on the buccal surface, you really have to try hard. That means you have to eat constantly or drink sugary stuff, and you're not allowed to brush your teeth for a year. So it's very much close to child neglect. And you ask what these people have also as a problem, that they don't recognize something is going terribly wrong. And some of them just go to the dentist when they can't sleep with a child anymore. So there's a high prevalence in Turkey, in Germany, and in many, many countries for early childhood caries. The decline of early childhood caries is not so pronounced as in permanent teeth or other dentition. So we have a polarization of caries distribution. It is some children with a very high caries load. And I already told you that it is actually very unusual, and you have to try hard to get a whole tooth ruined in just a year, and to have the smooth surfaces, buccal surfaces, really run down, as you see here. And this is the national data for Germany. We did the last survey here, and you see 12-year-olds in, here on the right side, you see 12-year-olds and the permanent dentition. And in Germany, we achieved a caries decline of 80%. And 80% actually means that now you have to wait 6 years and put 2 children together, that you can do 1 filling in those 2 children in 6 years. So caries in the permanent dentition hardly exists in Germany. We are as good as Scandinavia, Switzerland. But if you look in first grade primary dentition, that's the blue one in the middle, there you see that we only achieved a 40% caries reduction, and we have about 3-4 times more caries in the primary dentition than the permanent dentition. So something goes terribly wrong in the primary dentition in Germany. And it always takes a little bit here, because my slide has already moved, yours hasn't. Oh, I have to go on there. Okay, then it does. Okay, and we see here the 3-year-olds, and the 3-year-olds in Germany, they have 0.48 DMFT. And of these 0.48 DMFT, the big majority is DT. DT meaning that it's not filled or cared for. So we have a big problem there. The good answer, or the good news, is that something like 86% are caries free on a defect level, but that means that 14% of our children have these problems. And if you have caries, it's almost 4 lesions, and they are not taken care for, and 1 is fistula and abscess. So even in a great civilized advanced country like Germany, we still have a big problem there. Okay, I'll just go. Your slide is really a little bit slower. Now it's changing. I can see you on my screen here. I'm a little bit faster. So the general recommendations were that primary dentition is a transitional dentition. And so due to its transitional function and growth and development, you should not only look at the lesion depth, activity, and the optimal restoration. But with this very high level of disease, with the problems, with the children not being cooperative very often, you have to look at all relevant other factors. And all the other relevant factors, they determine something like facility structure, financing, insurance, social, psychological cooperation. They determine that you don't just treat the lesion, but you try to restore or control the caries activity and stabilize the general oral function and well-being. And if that happens in GA, it could be that you have quite some extractions there because you get new teeth anyway. And we have this polarized distribution. That means that 80% of the children don't have any problems and 20% have really high problems. And very often it is low socioeconomic status or migration. And so you should try with the next round of prevention to make a change in these children that clearly do not have profited from all our preventive effort yet. So moving here is a little bit slow. Our connection here is the picture is not changing somehow. Oh, I try to go on. Can you still hear me? The presentation does not proceed from here. Yesterday, it worked better. Yeah. Somehow the presentation is stuck. I try to go down here and see. I am at the presentation somehow doesn't move.
Can restart, Christian?
The presentation somehow does not move.
You can close and open again, maybe. For presentation, you can stop it and then restart again. Let's try this.
Do you see my window now?
No, not yet.
Do you see my window now?
Yeah. That's fine.
Yeah, I'll just go to down here. I think if I show you my screen here, that works better. Could you say okay that you see my screen now?
Yeah. Could you choose your
Hello, can you answer me? Can you show my screen now?
Yeah, you can share your screen 62 or 3. Listen, if you couldn't find, you can go like that.
Pardon me?
It's also okay for us.
What is okay for you?
Like I said, if you couldn't share your full screen, we can.
Yeah. I'll try. But it's difficult. So I stopped my screen now and I want to So I try again and try to have Bildschirmteilen. Okay. Do you see my screen now? My picture?
No, not yet.
Now you see it, okay?
Yeah, it's fine now.
Okay, so I try to continue there. Okay, I try to continue with the next slide. On the next slide, we have general recommendations. You should be able to see a small child with a brush hand. And it says that parents should be informed before the first teeth erupt about early childhood caries, and they should be, with the first teeth being present, be instructed in brushing teeth. And they should do that with a fluoridated toothpaste of 1000 ppm or more. And if I look at the Turkish toothpaste, which I got in Antalya, you don't have good fluoride in many toothpaste. So you really should stress that the small children do not have fluoride-free toothpaste or 500 ppm. They should use 1000 ppm toothpaste. If you have children with a high risk, high caries prevalence, then they should receive fluoride varnish treatments 2 to 4 times per year. And the sugar intake, of course, should be reduced. And if you, like in the picture down here, have even dentine lesions, non-cavitated initial, but even dentine lesions, you can inactivate that with just brushing with a fluoride toothpaste and putting fluoride varnish on it. And there is high evidence that especially these buccal lesions can be inactivated to a very high degree. And after half a year, you can restore them. You don't need to do GA or restoration right away. And if you have pulpal involvement, without pulpal involvement, even in these hard cases, you can use silver diamine fluoride. And the silver diamine fluoride inactivates all caries lesions, even if you don't brush. Very high evidence. There's very little stuff in dentistry that has such good high evidence as silver diamine fluoride. And what does that mean for the clinical practice? Now we are in clinics. Frasaco strip crowns and other preformed crowns should be preferred over fillings because fillings fall out and fillings are patched together. With a crown, you just crown everything and you don't leave anything of the tooth. And so any kind of crown, ceramic, stainless steel crown, Frasaco strip, plastic crown is better than a filling. And you should use that especially if you work under GA. And we don't need the teeth 1, 2, and 4. So we don't need incisors in the primary dentition. They don't have space maintainer properties. And the 4s, the Ds, can be easily extracted and you have space maintainers. So especially under GA, it's very questionable. If you do all you can do and restore everything in long GA sessions, which are expensive and risky, it is allowed and permitted and even recommended to do a lot of extractions. You never have pain again, and you do a space maintainer and you are finished. And so, yes, pediatric dentures are not fine, but sometimes it is more economic and practical to extract teeth, to crown the last tooth and make a pediatric denture. Now to the primary tooth, primary molars. As you see here in the middle is the sketch of a primary molar, and to the right side is the sketch of a permanent molar. You see, number 1, the enamel in primary molars is very small. So caries and bacters, our bacteria, get into dentine very quickly. Number 3 is that you have a big pulp and pulp horns, meaning that number 2, you have very little dentine. So there is nothing like really caries media where you can do a filling. You always have the problem of the pulp. And so if you have to do an proximal filling, like downstairs in picture C, the problem is you hit the pulp, you will have necrosis, abscess, and so on. So the American way is to cut out the pulp with a pulpotomy and do a stainless steel crown. The Scandinavian way is, if you don't have pulpal symptoms, you can just inactivate, brush, fluoride, and the pulp will recede. And if the pulp has receded, then you can do a restoration on it. And you can even do a whole crown, just plop a crown on there without prep, without caries removal, and you are very successful. So the non-restorative caries control, which is inactivation, is comparable to the results if you do fillings. And there is quite good evidence on that. So if you look downstairs here at the right picture, Nicola Innes and we in Germany showed, if you put a glass ionomer in there or just brush the teeth, the cavity, you will have the same results. There is no advantage for doing restorations for fillings in children. You can do that for aesthetics or function or whatever, but if you don't have caries activity, then if you leave the cavity open, no problem. If you have caries activity and fill it, you will still have secondary caries and it will go hoops. So a restoration in primary teeth does not really make a big difference. If you have patients that are not really cooperative, I already told you that if you put silver on them, when they don't have pulpal involvement, it automatically freezes and inactivates teeth, and that's highly proven. The whole technique also is very well proven. You just, if you don't have pulpal symptoms, have to pop on a crown and there it stays. Caries and Bactus, our bacteria, don't have a motor saw, and you don't leave anything of the tooth, you don't leave any nutrition for them, and so just crowning it, the American way with pulpotomy and stainless steel crown, or the whole crown without caries removal, just popping it out with any preparation, is as successful. They are both around 95%. And then there are many friends of arts and glass ionomer, meaning that you scratch it out with your hand, that you pop in glass ionomer, and glass ionomer does not work in proximal fillings. If you have a two-surface filling and use glass ionomer, it will not work. There is very good evidence that you lose all these restorations and then you are not happy. Occlusal surfaces, yes, fine, but not on a proximal lesions. And so in proximal surfaces, the whole technique with a stainless steel crown is much, much more successful than the ordinary caries removal and filling or just brushing teeth. Because with a whole crown, with a crown on there, it can't go wrong. If you leave the tooth there with or without filling and ask them to brush and they don't do it, you will have a problem. So this diagram shows you here a whole crown was successful, percentage 98%. The non-operative caries treatment was successful in 75%, and the filling to exactly the same degree, 71%. So we in our patients who are quite caries active, we have about 20, 25%, 30% that don't brush, and it really doesn't matter if you put a filling there or not, it will fail. And on the other hand, if you have a 100% compliant patient, it really also does not matter if you put a filling in there or not. If they brush, they will inactivate the lesion and it's all fine. Yes, with the filling, it looks a little bit nicer, but the filling doesn't make a difference. What always makes a difference is a stainless steel crown. And so for multi-surface restorations, you should use crowns. You should not use MOD fillings in primary teeth, and actually also not on permanent teeth. That will not be too successful. First of all, someone who has MO or MOD seems to be very caries active, and it will have caries, recurrent caries. And you have split the tooth into two parts, which is not too helpful. And so it will fall apart at some point, and a stainless steel crown covers this. And so I want to show you a couple of cases here where we did this. We had a 6-year-old child which came to our clinic, and it wasn't really cooperative. It was referred for going under GA. And we did desensibilization, tell, show, do, getting them used. And you can see that in all those primary molars, they have a problem, and very often interproximal. And you can see, well, it's here, unfortunately, top on top. So they interproximally everywhere have caries, but we will see that in a second. And we even had fistula abscess there in one quadrant. And that's how it looks. X-rays, terrible interproximal, some were already pulp. So extraction is always a good bet and successful, and stainless steel crown, because we have a high caries risk. Even if you could restore this with a filling. Yes, you could restore that with a filling. But someone who comes like this and has these oral health problems, do you trust him or her that they really brush here? And downstairs, it looks all great here, but it doesn't. You can guess there's caries here. If you take the X-ray, there's caries there, even on an OPG. That's cut out of the OPG, the opatogram. So you see that they have problem everywhere. Yes, you could do nice drilling and filling, but if patient doesn't brush, it will end up like those pulp polyps upstairs. So we did nitrous oxide with them. We did very careful injection there. We learned it from our Turkish friend to do anesthesia technology, very many injections, intraligamentary and everywhere. So first quadrant, stainless steel crown and extraction. Other quadrant, they both had pain and fistula and abscess, and then you can do a space maintainer, which we took. And they can always choose a picture, which was the dolphin here, so everybody in the Mediterranean is proud. And it was a boy, so he picked a white space maintainer. And then they wear this. And downstairs, we also did stainless steel crown. Yes, you could have done fillings, but not someone who is so highly caries active. So that's the end here of that case, and this lasts until the end. And you have a chance of restoration, of restoring it, of 5%. If you do fillings, you will end up with 50% of restoring it. So, and now last to the occlusal caries in the permanent posterior teeth. And the problem with the almost all erupting teeth is that they are lower. So if you brush on the occlusal plane, you don't brush them. And unfortunately, you don't brush them for something like 2 years, because that's how long they need to erupt. And in Germany, we have central registration of fees, and you see our dentists are basically, in spite of sealants and brushing and everything, and fluoride varnish applications, they are only basically drilling on the first molar occlusal. And as I told you, that's just because everybody does brush, but they do not hit the occlusal plane because the tooth is smaller for a long time. And so with erupting teeth, permanent dentition, especially molars, because they are especially slow, you should instruct your patients that they brush cross or sidewise from the side perpendicular to the line of teeth, and they should do that with a full fluoride toothpaste, which is 1,450. If you have risk candidates, risk teeth, risk individuals, or risk populations, then you should do fluoride varnish treatment there for prevention. So in Turkey, with some higher caries levels, you should do it in everybody. In Switzerland, you should do it at less people. Okay, picture is still in line. I go back to my presentation, but your sound is off, but I hope you can hear me still. And then we are coming to minimal restorations and to sealants. Sealants are very expensive. And if you seal something like in Denmark or Scandinavia, where nobody gets caries, all teeth, you spend a lot of money. And you don't want to spend a lot of money and have no effect. So sealants should be, like fluoride varnish treatment, be limited to individuals, teeth, groups, and populations with high caries risk or activity. And normally they should be done with composite presence. Sorry, but if you have high risk individuals, they need that very soon. So you should already probably seal during eruption, and then you have a moisture problem. And so it's very advisable to use glass ionomer there. And the non-cavitated lesions should preferably be inactivated. Fluoride treatment, brush, and then if that does not work, then you can seal them in order to rest it. So first is the non-operative treatment, and then of initial lesions, you have the operative treatment. And if you have already dentine defects, caries defects, cavities, then of course you treat that with a nice composite, only the defect. And as somebody has advanced or prolonged caries risk, you seal all the other pits and fissures, and that's called preventive resin restorations in the US. You don't do extension for prevention anymore and do a composite or amalgam for all the surfaces. So the conclusions are, as the caries process manifests itself in subclinical demineralization, initial caries lesions, and finally cavitation, it can be treated with, first of all, non-operative, micro, and minimally invasive measures. It is almost impossible to draw a clear cutoff line between prevention and therapy, because if you brush healthy teeth, it's prevention. If you brush decayed teeth, it's therapy, but it's still brushing. And the main treatment process is to change the imbalance of D and Riemann. So fillings, restorations don't help as long as you have teeth and still lose minerals. So the main thing is caries management of caries activity, and you have to reduce it, because somebody who has caries up to now was not successful. So the main treatment of this consensus is caries management, reducing caries activity, and not the restoration, especially in primary teeth, because you get new teeth. And especially true for primary and erupting teeth, because they are vulnerable, and children and adolescents are vulnerable, and they are still growing. And here you lay the foundation for the whole pathway of oral health for your lifelong. And besides the well-researched and established preventive approaches and treatments for permanent teeth, the success rates in primary dentition, especially for early childhood caries, are suboptimal. So we have there lots of caries, more caries than we should have, and our restorations do not last as long as we want. And so the thinking of a pediatric dentist in cariology is a little bit different than we all learned it in dental school. Cut out the brown stuff and put a nice filling in there. So thank you for your attention. And do you have any questions?
Okay, thank you, Christian. This was really excellent and full of knowledge. Thank you very much. I will ask the audience if any question. Sorusu olan varsa alabiliriz. Soru sormak isteyen var mı? I think no question, Christian. Thank you very much once again. Hope see you soon.
Okay.
In Orca.
Okay. Then all have a nice, successful meeting there.
Thank you.
And a good week. Okay. Bye-bye.